Jayashri Kulkarni commenced her appointment as Professor of Psychiatry, the Alfred and Monash University in 2002. She founded and directs the Monash Alfred Psychiatry Research Centre, a large group of dedicated professionals discovering new treatments, new understanding, and new services for people with a range of mental illnesses. Graduating in medicine from Monash University in 1981, Jayashri became a fellow of the College of Psychiatrists in 1989. She's conducted groundbreaking clinical research since then and is internationally acknowledged as a leader in the field of women's mental health, in particular for her innovative work in reproductive hormones and mental illness. Now, deservedly, Jayashri also received an Order of Australia in 2019 for her services to psychiatry. So, Professor Kulkarni, we are delighted to have you join us at Pure Health Hub.
Thank you so much for inviting me to be here. I'm really looking forward to chatting to you.
Lovely. Now, I guess I should preface this interview by pointing out that not all women suffer from adverse effects of menopause, but it does seem to be a relatively small number, right? But it's still a significant number of women. So, but these changes for those women can be destructive on their mental health. So this is the topic of our conversation today. So we understand that female hormones control fertility. However, they can also influence brain chemistry, impacting mental health and mood. What are these hormones and what are their purpose, obviously aside from fertility, and how can they work against us or even how can they work for us in midlife?
So there's a lot in this, and the main hormones that we're talking about here are estrogen, progesterone, and testosterone. They would be the main, what we call gonadal steroid hormones. They really are the key drivers of, in women, ovulation, implantation, and then keeping the environment productive for the development of a fetus, and then birth, and then lactation, and so on. So there's a lot of the hormone known information to do with reproduction. But these same hormones are potent neurosteroids. They're all steroid hormones and they all work in the brain. So when you look at the receptors for the hormones in the brain, they're enormous numbers. And so all through the brain, these hormones actually have a very vital role to play in maintaining mental health. And what we've done over the years is somehow we've got ourselves into the situation where we've seen the hormones as kind of really only relevant from the waist down and forgotten about the fact that there's this big organ called the brain, which really, you know, has got the overriding function for a whole range of functions, including mental health and well-being, cognition, thinking, higher education, learning, all of those things. And so it's not surprising then when we have fluctuations in estrogen, particularly, which happens, and progesterone, which happens around the menopause, that this takes its toll on the brain as well. In some women, as you mentioned earlier, there is a significant new depression that occurs because of the menopause, or women who've had depression who suddenly get worse as a result of the menopause. Mm. And in the past, their stories were wrongly discounted and invalidated. And I think it's really important to call it like it is, because there's a lot of neuroscientific evidence, particularly growing in the last 5-10 years, that shows just how potent estrogen, progesterone, and testosterone are in the brain of women.
Right, so they've been somewhat neglected, haven't they? As you say, just literally from the waist down. Right, so aside from periods, pregnancy and childbirth, there remains this confusion or vagueness around women's reproductive health, which is, I guess, you've just explained it a bit, even today it can be difficult to get a definitive diagnosis. Like, I certainly wouldn't be alone in that, which of course is understandable given the gender bias in medical research. Why does medical research neglect women, or is it a one-size-fits-all approach to mental health actually work?
Well, to take your last point first, I definitely do not think that one size fits all works. It just doesn't. Gender blind approach in medicine and health in general has really, I think, disadvantaged women in lots and lots of different ways. But similarly, I think the silos that medicine operates in, specialist silos in particular, have also disadvantaged a large number of the population. So, for example, experts in gynecology dealing with the uterus, ovaries, pathology thereof, and obstetrician who are dealing with childbirth aspects would not be looking at the brain in the same way that, say, psychiatrists are dealing with the brain, and neurologists, who then don't particularly consider the body of the woman. So I think what we need to come to is a different way of really having a much more integrated and holistic approach in medicine, which then benefits our patients, and in particular women. Because for something like mental ill health conditions like menopausal depression, and it's in the name, there's a hormone component, the menopause, but there's a psychological component, which could be all sorts of things like what she's experienced in terms of her own ways of coping, of solving problems, of coping with stresses and so on. And then social, which is the environment. So she might be coping with domestic violence or financial stress or poverty or housing issues or all sorts of things. But none of those are separate. They all integrate with each other. And I think we need to understand a lot more, and particularly in this area where the menopause hormone fluctuation really has a critical role to play with depression in middle-aged women, and is often ignored as one of the key factors that's driving this particular depression.
Because it seems to me that they consider the depression almost an environmental element rather than a biological one or a psychological one, and therefore it sort of sometimes gets pushed to the side, right? Okay, now you've worked in this area for 25 years. Bravo. To improve the quality of care for women with mental illness by developing specific treatments that are tailored to each woman's needs, biologically, socially, and psychologically, which is what you were just saying. But what are some of the additional issues that women are presenting with that you're finding is the prevailing cause?
So many times in my clinic, and I have a specialist women's mental health clinic, and it is a tertiary referral clinic, which means that women have tried standard treatments through their GPs and may have tried psychiatry or psychology type based treatment. So they're coming after all that hasn't really worked terribly well. So I've got a very unwell group that I'm working with. But what we're seeing an increased number of women with dreadful depression and anxiety, which has begun in the mid-40s and really hasn't responded to standard antidepressant treatment or psychotherapies that go alongside the antidepressant treatment. And when you go back and look at the stories of what has happened, the missing factor here is exactly that this whole issue for the woman started when she got to her mid-40s and is approaching menopause, not forgetting that menopause in the brain starts first in the mid-40s. And so it takes another 3 or 4 years before the hot flushes arrive. And all of that's been missed in the sort of, okay, she's got depression, let's treat that, because we get into this blinkered view that that's what it is. And unfortunately, the response that the woman has been able to make has not been brilliant. I mean, there are many women who will get about a 30% improvement or a 40% improvement, but it's not enough. And in the meantime, her whole life, if you talk about somebody having untreated or unresolved depression for 5 or 6 years, that's a lot of time to spend not enjoying life, destroyed relationships because, again, there's no life in the person, difficulties with work and maybe even losing job. And then the worst is the suicidal thinking that when women who have a very severe form of this get into the mindset of, what's the point? And there is an increasing statistic in the Australian Bureau of Statistics data that shows us that as a group, middle-aged women from 45 to 52 are the second biggest demographic group that commit suicide. The biggest,
really?
Yeah, the biggest is men over 85. So this is, perhaps not talked about very much or not understood. It's not the actual numbers, but the actual demographic group of middle-aged women are in trouble. And when we think about all the roles that middle-aged women hold down, I mean, they're the mums of adolescent kids. They're often the senior managers in the workforce in various forms. They're often the carers for elderly parents. And then you've got, the whole sort of issue that because women are living to the mid-80s now as more of a rule, that's a long time to spend not enjoying life if it's not picked up and helped. So this is why, we've got to get our act together and actually try to bring a different form of looking at things in a holistic sense.
Exactly. So why is it so difficult to get specialists and doctors to the table to talk about a patient? Now, I do know that this does happen in Asia a lot more readily. I mean, I'm sure it happens here somewhere. Certainly in your clinic it does, certainly your centre. But why is it so hard to get them to come to the table? Is it time, money? What is it?
I think there's so many reasons. Time and money will be part of it. And, in the public sector, you've got the pressure of the numbers of people who have to have a service provided, and the time is a factor there. In the private sector, you've got specialist practices that are set up exactly as that. And so the specialist will consult on her or his own specialty, but not have the privilege of having other people around to say, in the corridor, what do you think? What can we talk about, Joan X, etc. So it becomes a whole range of issues. But I also think it's in the menopause situation. If we focus on the menopause and depression, none of the specialties really own menopause. It doesn't quite belong to gynecology. It doesn't quite belong to endocrinology. Certainly the psychiatrists don't want to have anything to except me and a couple of my colleagues. No one else wants to know about it. Yeah. And it's kind of like the orphan situation.
Yeah, right.
And so, and also I think there's this thing that we've still got a little bit of, shh, don't talk about it.
It's amazing.
Yeah, and so all of that and that sense of every woman goes through menopause, grin and bear it. And that's often the message that many of my women clients will tell me that their mothers have said to them.
Absolutely.
But
then their mothers also perhaps often didn't have the same stresses and the same lifestyle, the same environmental factors that, that we deal with today. So, and also, it can go down the food route and everything else. But yeah, it's extraordinary, isn't it? It's very important for me to bring this whole menopause out and shout it from the rooftops, to be honest, because I really just don't want it to be this kind of something that's quiet on the down low, in a silo, because half the population has to go through it. So, so then how important is it for the research to be conducted in a live clinical setting as opposed to just in a lab? And why is that?
Absolutely important for it to be in a live clinical setting and translated into the community. So one of the things that I think is really important is, we've done clinical trials looking at hormone strategies as a treatment and then published that in the relevant medical psychiatric journals. Okay, tick for my medical journal reading colleagues, but that doesn't get out to every person in the street, and that's males and females, because I don't think women's mental health should be women's secret business. It's not. It should be everyone's business. So, we need to get somehow from out of the lab, take those findings from animal work into clinical so that you've got new treatment strategies and understand that, but then take that out into the streets so that you can actually educate everybody and also educate the health professionals to open their eyes to, when the next 47-year-old woman walks in the door and says, all the symptoms of depression, but I've never had anything like this before. Think about what else could be going on.
Yeah, exactly. Out of those books and into the office, right?
Absolutely.
So we've got to aim for that. All right. So in my humble opinion, hormone replacement therapy, or hormone therapy, as it's now known, I'm told, has had a bad rap. Now, I had a very positive experience with this treatment. What's your view? Can hormone therapy assist?
Well, I mean, I've spent decades researching hormone therapy. I think the bad rap, though, came from the Women's Health Initiative study, which was published in 2000, 2001, the big headlines that came out saying, you know, throw away your hormone therapy or you'll get cancer. Mm-hmm. And it was a very powerfully bad media headline grabbing type campaign. I'm still not quite sure how it all came about, but the study, you know, was looking at whether hormone treatment would prevent heart disease and strokes, and no, it doesn't prevent heart disease and strokes. No one ever, you know, that would be ridiculous to think we would be using hormone strategies to prevent that. That's not it. But that's different to if somebody is really struggling with menopause symptoms, physical and mental, they need to have an effective treatment. And, you know, as one of my patients said to me, isn't it bleeding common sense that if it's the hormones that cause the problem in the first place, wouldn't you want to have a hormone treatment to fix it? And she's dead right. You know, it is bleeding common sense.
Well, it seems it to me, you know, I think when I've said to women, you know, that I was on HT and they were like, oh, really, isn't it? You know, they were terrified. In fact, but someone rang me the other day and said, I have to thank you. And I said, why is that? She said, because I finally went and got some hormone treatment. And she said, it's changed my life. Yeah. And I said, well, exactly. Why are we going to live for 5, 7, 10 years in a miserable state, but not only psychologically, but physically, right? I mean, Absolutely. It just makes no sense to me. It's just so I'm a huge proponent for it. But anyway, that's me.
Well, we still have to be careful though. We've got to do all the good health monitoring stuff.
Yeah.
And that is important, but it's important, you know, for everyone.
Generally. Yeah.
Anyway.
And particularly at this age, right?
Yes,
so
yes, absolutely.
You know, we can get through and get away with it in their 20s and 30s and even 40s, but you know, really it gets to a point where the monitoring has to come in. So can a history then with the contraceptive pill affect midlife mental health?
Yes, it can. And in our work, what we find is there's a sort of a theme that runs through. So the woman who, for example, has terrible premenstrual depression, and I'm not talking about PMS, that's with the bloating and, you know, a bit of pain in the breast and a little bit of physical discomfort. I'm talking about the actual crashing depression that about 12% of reproductive age group women experience. So that woman is much more likely to develop postnatal depression and is much more likely then to go on to perimenopausal or menopausal depression. So it's kind of a theme that runs through in that there's something in this woman's brain that means that fluctuations in her gonadal hormones, estrogen, progesterone, testosterone, make her very sensitive to depression.
Well, it's biology, right? I guess that's, it just keeps,
it is an individual variation because not everybody has that vulnerability to fluctuations, which is also why it's important that we don't medicalise menopause or menstruation or any of the events, but Absolutely. We have to be there to help the person who's struggling. That's what medicine's about, you know, helping the people who are struggling with something.
Absolutely. I see these things about, you know, women wanting to get, you know, I'm probably going down a rabbit hole here, but, you know, when they want to have period leave or you know, menstruation leave or whatever. And I just think really, you know, we shouldn't be medicalising it. It is what it is. And you'd be taking sick leave like anything else, right? If you were stuck with, certainly it was my issue. But, you know, I think we'll probably end up down a rabbit hole. All right. So, okay, then with the onset of midlife hormone-related mental illness, is it more like, as you just said, really, it is more likely in women who have had postnatal depression. So there is that that cycle or that goes through a woman's life. So then, all right, so do men and women have different patterns of mental illness, and are women more exposed or exposed to different risk factors and vulnerabilities?
Absolutely. And this is why I think, we have to think about the gender of the individual in front of us. And of course, that includes the non-binary approach and all sorts of things, because there is so many differences. But if you took a standard look at males and females, there is already in the data a very marked difference. So women experience anxiety disorders about 4 to 1 times more than males, experience at least 2 to 3 times more depression, and experience 12 times as much eating disorders, as well as experiencing about 5 times as much post-traumatic stress disorder. That's just the actual, incidence prevalence of mental ill health. The types of presentations are all different as well. So, for example, even in a disease like schizophrenia, there are different presentations that men and women have with different symptoms and different age onsets and so on. So, there are marked differences, because with the brain, the gender, the actual male-female biology of the brain has a whole range of biological factors that play out. Sure, there's social, environmental factors and psychological factors that are a spectrum, but nonetheless, there are some biological differences, and we need to be cognizant of that when we're trying to develop new strategies.
Absolutely. Gosh, it's such a broad spectrum, isn't it? And I do understand how it's very difficult for the medical fraternity to pinpoint, no doubt, which is why I think it's really important, right, that we need to own our own health journey. I mean, it's very difficult with someone who's depressed, because I had a long term of that as well. And it's very hard to sometimes get your head out of that. But for anything that we do, right, is about owning our own health journey and doing our own research, so that we can be well equipped to be able to communicate this to our doctors, our GPs and our specialists. I remember going into doctors and just going, well, this is how I feel. And they were, well, where and how and what? And I'm like, I don't know. It's like, you can't, you've got to be able to give, I think, and take responsibility. But thank you so much for that. That was brilliant. We could obviously go on for hours, but I'm so grateful to learn so much more, and also learn more about the fact that there's more collaboration happening in this space. And so we hope to talk to you again. Thank you, Professor.
Thank you so much. My pleasure.
Have a great day.
You too.
Bye.